Usually you have to see the passive movements only.
Yes, sir.
There will be a lot of them. So we have stabilized
when there is non-union, hello.
Yes, sir.
The examination of elbow movements and shoulder movements, it is very easy to examine if the patient is supine. The elbow is supported and easily you can stabilize the distal fragment, the distal part of the fracture site, and you can easily do the passive flexion and extension. In a sitting position, it is very difficult to examine the shoulder movements and elbow movements. But in supine position, passive movements are very easily you can examine.
Yes, sir.
Because you have to stabilize the fragment.
Okay, sir.
So whenever there is elbow stiffness, there is an angulation of the distal fragment of the fractured part of the humerus. So if there is a stiffness, so it is best to stabilize in a supine position. It is very easy to stabilize that distal side.
Okay, sir.
So now we can tell the diagnosis again.
Okay, sir. My diagnosis is a case of a mobile non-union of a left humerus mid-shaft in operated case with a 5 centimeter shortening with angular deformity without elbow stiffness for a 2-year duration in a 56-year-old male disabled due to inability to lifting weight and daily activity without neurological deficit.
What are your points?
Yes, sir. Yes, sir.
Yeah.
Soumik.
Yes, sir.
We are not going to accept the deformity part of it. It's only just the abnormal mobility showing the deformity. Deformity is always a fixed one.
Okay, sir. So
I think this is a mobile non-union. You cannot say deformity.
Okay, sir.
Sir, please clarify, Gopakumar, sir.
Yeah, that's true.
Yes.
Because, in whichever way you will be able to make the deformity, isn't it? When it's mobile.
So when the deformity is you able to correct by yourself or patient, it is not a deformity. Please remember that.
Okay. Okay, sir. Yes, sir.
Because it is when you are trying to contract the biceps or muscles, then there will be angulation. You cannot say it is a deformity.
Okay, sir.
Okay. Even fresh fractures also you can see when there is a patient is conscious, you try to contract, then you will see the angulation. Once it relaxes, the angulation disappears. So you cannot say it's a deformity. Okay.
Last 4 minutes to finish the case.
So investigations. What will you like to do?
Sir, I would like to do an X-ray full length of left arm epilateral view, and also do a blood investigation, blood investigation, total blood count, ESR and CRP.
दिखाओ.
Sir, Henny. It is not available. Hello.
Yes. The X-ray is available.
Yes, sir. X-ray is available. Sir, the first one is the day of trauma. Second with bleeding on a second day. And third
last
one is
X-ray you put. Last X-ray.
Okay, sir. Okay, sir. This is the last, second last is last X-ray, sir. In September 2020. In May 2020. Second last is the last one.
You don't have an X-ray after removal of the reference?
Yes, sir. Yes, sir. Recent X-ray I don't have.
So what do you think the cause of non-union?
Sir, it is due to inadequate fixation.
Yes, book of master.
Yeah, what according to you, what might have caused the non-union? What are
Cause
the
of
factors?
yes, sir. According to me, cause of non-union is inadequate fixation.
Why it is fixed by intramedullary as well as external fixation? Isn't it?
Yes, sir.
Then why do you say inadequate?
Sir, my external fixation was removed after 8 weeks of incision, and at that time also there is a mobility at fracture site. According to patient, there was inadequate fixation and inadequate immobilization. Both are the cause of this.
Anything else?
No, sir.
Otherwise, tell me common causes of non-union of the humerus.
Okay, sir. Okay, sir. Sir, inadequate mobilization, inadequate reduction, inadequate fixation. Even in compound fracture, there is inadequate blood supply.
Yeah.
And inadequate opposition due to distractions.
Distraction. Okay.
Distraction.
Okay. What do you think? What type of non-union is it?
Sir, although I have not recent X-ray, but from this X-ray, I can say this is a atrophic type of non-union.
What causes atrophic type of non-union?
Sir, inadequate inadequate fixation and poor blood supply cause atrophic non-union.
What type of non-union?
Pardon, sir?
Instability. What
Instability.
type of non-union does it produce?
Sir, instability, oligotrophic, hypertrophic non-union.
Hypertrophic.
Instability.
So, thinking back, what might have been the cause of non-union here?
Sir, here cause of non-union is displaced fracture fragment and inadequate fixation. Both are the.
Yeah, initially a plate fixation, isn't it?
Soumik.
Yes, sir.
Gopakumar sir, please proceed, sir. Gopakumar sir.
No, you can continue.
Soumik.
Yes, sir.
So you have to for a fractured unit, you have to satisfy both biology and mechanics. So these are the two factors that decides the union. Okay. You
sir.
just tell us which is failed here. If the biology failed or the mechanics failed, or both are failed.
Both are, sir, because there is inadequate fixation and inadequate distraction also at fracture site, biological and mechanical.
Biology only you can predict only. You don't know what happened because unless it's a compound fracture, you cannot say how much blood supply disturbed there. No?
Okay, sir.
So it is mainly the primary blame goes to the inadequate fixation.
Okay.
Okay.
Time up, please.
Just
Last 5 minutes, if at all, with chief examiner's consent. 5 more minutes, if Gopakumar sir permits.
Yeah.
Gopakumar sir, we want to see the top film. That top X-ray we want to see in detail. Down. Or take it down. Can you take down? Because the entry point in humerus.
Yes, sir.
Entry point in humerus.
Yes.
Looks to be improper. So there is angulation in the beginning. Yes. Middle. No, take up. ऊपर लो इसको. Soumik.
Yes, sir.
Atomic और ऊपर करो.
Yes, sir.
No, you are going down.
Down.
You go reverse.
Okay, sir.
Or
Yes, sir.
or next. This picture.
Sir, first one.
No, middle one. Gopa Kumar sir.
Middle one. Okay, sir. Middle one.
Middle one.
Yes, sir.
Already there looks to be angulation in the beginning of itself.
Okay, sir. There is proximal fragment is slight angulation at beginning of while operated with plating.
And after nailing, there should not be any angulation.
Yes, sir.
Gopa Kumar sir, please your comment.
Yeah, the main thing is I think he has the surgeon has used an LCP, locking compression plate.
Yes, sir.
Yeah, and actually for such fractures you require interfragmentary compression, especially in the humerus.
Yes, sir.
And I see that entry point is quite below the head.
Yeah. So
Sir, in this case,
here the nails are also very short.
yeah.
Yes, sir.
But ultimately, this patient went in for a Elizuro. That is a different story because I did not give him the other X-rays post coming to me. This
So
is
in the exam, what will you suggest as the treatment?
Sir, I would like to rule out ESR and CRP for infection if it is normal.
No
you want
infection.
to rule out infection. You don't want
Infection.
to rule out ESR and CRP.
No, sir. Sorry, sir. I want to rule out infection by ESR and CRP. If it is normal, then I would like to do dynamic compression plating with bone graft. After opening the fracture site, I have to freshen the bone ends, open the medullary canal, and remove the fibrous tissue at fracture site, if any.
So what is the length of the plate that you will use?
Sir, minimum, sir, 4 hole above, 4 hole below.
This
So
type of
9 hole dynamic compression plate is enough.
9 hole. This type of plate?
Dynamic DCP plate, sir. Dynamic compression plate.
There are various types: 3.5 DCP, 4.5 DCP.
3.5 DCP.
What?
Sir, 3.5 DCP plate.
3.5.
Sorry, 4.5 DCP, 9 hole 4.5 DCP plate.
Okay, you want one with staggered holes or straight holes for the humerus?
Okay, did you listen to class of Kakatkar sir where he told about staggered plate, staggered DCP plate?
Yes, sir, but I don't remember now.
Yeah, I asked this question because in Schatzker's book on fractures, they advise this staggered holes because humerus is one fracture where it can split if you put all the screws in a straight line.
yes, sir. They said broad DCP also. They said
The staggered holes is what is advised.
yes.
Okay, which approach will you use?
Sir, I would like to go with the posterior approach by tricep splitting.
Okay. What is the disadvantage of that approach?
Sir, if iatrogenic injury to radial nerve, then there can be neurological deficit.
So radial nerve injury can.
Yes, sir.
Usually it doesn't occur because you are seeing the radial nerve.
Yes, sir.
Okay. Now the fracture has united. What will you advise the patient regarding implant removal? The patient is coming to you after 1.5 years.
Okay, sir.
And patient is asking, he wants the implants to be removed or the plate to be removed. What will you advise? We don't have time. You just answer.
So, I don't know, sir.
Yeah, because you are putting a 9-pole plate in the middle of the humerus. Therefore, the chance of a radial nerve injury occurring during the plate removal is high. It is much more than during the primary fixation.
Okay.
So you should get consent for all these before advising plate removal. Okay, if you look at the incidence of radial injury following surgery and implant removal, in the plates put posteriorly, it is much higher after implant removal.
Okay, sir.
Anything
Sir,
else?
our time is over. Gopakumar, sir, I will request you for your final remarks, sir.
Yeah, it was a very case and a very common case that is kept for the exam. And only thing, but you should confine your presentation to history, relevant points in the past history, personal history, and then inspection findings, palpation, movements, all neurovascular deficit like that, and tell the diagnosis. Then you tell only the relevant investigations that is necessary for this fracture and treatment. These are the only things that will be asked in your exam. Okay?
Okay, sir.
Then in all these cases, whenever there is a non-union, the examiners will ask you what is the cause of non-union.
Okay, sir.
Why it has not failed to unite. Then you have to say whether it is the biomechanics or biology or both which has failed.
Okay, sir.
That's all.
Stop sharing your screen.
Sir, Somik's result is what, sir?
Somik passes, sir.
Okay.
Thank you, sir.
Okay, next case from Calcutta.
Now, Shivananda, sir, you please be ready as an examiner along with, I will request Jayant, sir.
Yes, yes, I will definitely.
And Gopakumar, sir, will be chief examiner.
Okay, okay.
Please start your presentation.
Good evening, teachers. I'm Dr. Rivudip, a third-year resident in Peerless Hospital. I'm presenting a case of...
No, we want it as an exam, this thing. This is your short case. You have directly to be asked by the examiner, what is your diagnosis?
Right, sir. So this is a case of post-traumatic, post-surgical stiffness of the right knee without habitual dislocation of patella for a duration of 2 years in a 19-year-old male patient with intact distal neurovascular status.
Okay. Why do you call it as post-traumatic, post-surgical stiffness?
Sir, from the history, the patient, sir, I would like to go to the history slide, sir. Can I, sir?
Can you tell?
Sir, from the history, the patient sustained a trauma to the right knee 2 years back. And following the trauma, he underwent the index surgery 3 weeks following that trauma, probably by open reduction and internal fixation from the large anterolateral distal femur scar, which I can make out from inspection. The details of the operation were not available. He had undergone that surgery 3 weeks following that trauma 2 years back. And after internal fixation of that fracture, patient was being rehabilitated and he gradually developed stiffness of the right knee with inability to sit cross-legged, inability to squat, and he also had difficulty in climbing stairs or alighting a flight of stairs. The deformity was non-progressive over the past 2 years. He had undertaken some intervention following the complaints of stiffness. 1.5 years from the present date, he had undergone an arthroscopic arthrolysis for the stiffness.
This was told by patient.
Sir, he had actually described the procedure. He was referring to an arthroscopic procedure. So possibly, sir, patient had undergone an arthroscopic arthrolysis. And even after that procedure, the symptoms of the patient did not improve substantially. So and also because of the intervening pandemic situation, he was not able to follow up in hospitals on a regular basis. So the patient has come
That is
to
very
our
detailed history. There's a very detailed history. When you're presenting a short case, you just to tell what are the positive findings. That means there was a trauma, following
Yes,
which
sir.
he was operated, following which there was no physiotherapy, or whether the physiotherapy happened or not happened because of lockdown, whatever it was. And at present, non-progressive deformity in which form? And
Sir,
what has it affected him? It has affected his activity of daily living in the form of squatting, cross-leg sitting, and
climbing stairs, sir.
getting the stairs.
Yes, sir.
Okay.
Uh,
And meanwhile, one surgery done 1.5 years back
1.5 years back, sir, he
without
underwent this,
improvement.
without improvement, sir.
That much is more than enough.
Yes, sir.
This is a short case.
Right, sir.
Yeah.
Sir, other points relevant to the history, I had inquired about the appearance of the episodes of fever and or any discharging sinuses over the local area, which the patient did not complain of. And also there was no other history like administration of multiple intramuscular injections in the thigh.
Okay.
Sir,
So, Jain Sharma sir,
Yes, sir.
this multiple injections in the thigh, when it is given, you can ask.
Yes. Saha Saab, when are these multiple injections given?
Like, what are the indication if it is at all given in the thigh?
so I'm not sure, sir, actually.
So why did you mention it?
Sir, actually, this is in order to rule out the progressive history, sir. Mostly this is relevant in case of pediatric patients, sir.
So you have to be very specific with your words.
Yes, sir.
You are inviting problem for yourself by giving these type of loose ends to the examiner.
Sorry, sir.
Okay.
Now, what is his problem?
Sir, presently, a patient is having difficulty in climbing stairs and alighting the stairs. He's also having difficulty running. Previously, he used to be an active athlete, and he's having difficulty in doing that. And also, among the activities of daily living, he's having difficulty in sitting on a chair. And he has developed loss of flexion in the right knee, sir.
Okay. You said something regarding the patella, isn't it? In your
Yes, sir. Yes, sir. So there is no history of dislocation. So I have also examined. So the patient is not giving any history suggestive of habitual dislocation of the patella.
no, in the original diagnosis, you have written something. That was what I was thinking.
Yes, sir. Yes.
Why did you use the term without habitual dislocation of the patella for a post-fitness of the knee?
So in a post-surgical case, this is not very relevant, sir. It is most.
Then why did you add in your diagnosis? Because habitual dislocation of the patella is entirely a different entity.
Right. Sir.
More common in?
Sir, in pediatric group, sir. Okay.
Pediatric groups, and it occurs some specific.
More common in females, adolescent females.
Adolescent females.
So, if you have said recurrent dislocation, that may be still little, but you have said a habitual dislocation. Yeah. So I was thinking why you put that as in your diagnosis. Okay.
Okay.
So do you want to add anything in the regarding the patella in your diagnosis?
Sir, without any recurrent dislocation of patella, sir, it would have been.
No, even
what other thing usually occurs to the patella when there is stiffness? Extra.
Sir, there can be a reduction in the patellofemoral excursions.
So what is that known as? What is tracking, mal tracking of patella?
Sir, that patella stays within the trochlear groove while during the knee flexion, and it does not dislocate laterally.
Okay.
So adhesion in the patella and the femoral condi. That can be a cause of stiffness because the patella will not move.
Right, sir.
That you can tell if you want. Okay, what are your inspection findings?
Sir, from my I have inspected the patient from front, behind, and sides in the standing position and also in the supine position. From the front, sir, I can make out visible wasting over the right thigh region. From behind, there is there is symmetry of the popliteal folds on either side. From the sides, there is no evidence of genu recurvatum, and from the supine position also, sir, there is a visible wasting over the right thigh. Sir, I can. I've corroborated that with my measurements. There is a 2 centimeter.
On inspection,
Sir.
From front, you were saying something about the scar when you were describing something history while you're giving the history.
Yes, sir.
You have not mentioned anything about that.
So there is a
you have not mentioned about the position of patella, whether it is facing laterally or facing forward in supine and in standing position.
So in the standing position, the patella is facing forwards, and in the supine position, the patella is facing a little outward.
Little outward. Again, last time only sir told you this word little, bit, more, less is not allowed.
So patella is not directly pointing towards the ceiling. It is
apparently there is some 10 degrees of outward position of patella and it's not facing the ceiling. How it would sound if you say like this?
Patella is looking outward, sir.
So by 10 degrees?
Yes, sir.
Or anterolateral facing like Gopal Shinde sir has said?
Yes, sir. So there is a scar, a healed surgical scar over the.
Healed by primary intention, secondary intention?
So this is there is a hypertrophic scar, sir. So primary intention, sir.
Why it is important to comment on the intention of healing of the scar?
So in order
had
to
it been an infected case, what would have been the intention of healing?
Secondary intentions.
So that is what was expected as answer from you.
Yes, sir.
Okay. Go ahead.
Sir, from the sides, there is no genu recurvatum.
Why you are saying genu recurvatum alone? Why can't it be flexion deformity? You just say that there is no sagittal plane deformity.
No sagittal plane deformities.
Then.
Okay. Sir, on I would like to progress to palpation. On there is no local rise of temperature, and there is no bony or joint line tenderness, with no evidence of effusion, sir. In the movements,
could you palpate the implant?
No, sir.
Was the scar adhered? Sorry, sir.
Scar was it was looking adhered, sir. I felt it adhered, sir.
Where? The bone?
Not to the bone, sir. Iliotibial tract, maybe, sir. Over the lateral side.
The lateral side.
Yes, sir.
Where is the scar?
So it's on the anterolateral, sir.
Anterolateral. Okay. Did you palpate the bone underneath?
So I could not palpate. So I palpated the femoral condyles.
Yeah.
There was no irregularities as such.
You could palpate the lateral condyle?
No, sir. The medial femoral condyle was more easily palpable, sir.
Okay. Did you compare it with the other side?
Yes, sir.
What
That is
about the
important. Sorry, sir. Go, sir.
continue, sir?
No, sir. I was just asking what is the significance of comparing both the sides. That's all.
So in order to make rule out any adherence of the tissues, any adhesions on the pathological side, sir.
Did you palpate the patella?
Yes, I palpated, sir.
What about movements of the patella?
So there was, sir, the patella was not gliding to at least 2 quadrants medially. So the excursions were limited.
Okay. Any palpable implants under the skin?
No, sir.
So these are the things which you will have to palpate, isn't it?
Yes, sir.
Just Gopa Kumar sir.
Yeah.
These slides are not allowed in the exam. Is he reading the slides? Or why there should be slides?
Yeah, actually they will have to say, without using the slides.
Yes.
But they can show the pictures if they want. Pictures are allowed, but not the written materials.
Devadeep, now flexion deformity is there now?
So there is not a there is no fixed flexion deformity, sir.
No fixed flexion.
Then movements. Come to movements.
So in movements, the range of motion of the flexion in the right knee was 0 to 45 degrees, which was painless in both active and passive ways, sir.
Can you show the picture where you measured it?
Sir.
Okay. Tell me, where did you put the goniometer? Exact location of goniometer.
So parallel to the lateral, parallel to the medial joint line on the lateral side, sir.
Parallel to the medial joint line on lateral aspect?
So the center of the goniometer I have tried to place on the lateral joint line, but it was not very discernible out there, sir, because of the maybe because of adhesions underneath, sir.
Surface marking for placing a goniometer in the knee joint.
Sir, over the lateral joint line on the lateral side.
The first point you mark is at what?
Tibial tuberosity, sir. I go upwards from the tibial tuberosity along the joint line in 30 degree of knee flexion, sir.
Kopa, sir?
No, what he is telling is not right.
Yes, sir. I also feel it's not right. A point on the center of patella in full extension and then equidistance on both the sides you have to go.
Yeah.
That is what I think so. I have read. I'm not very sure. Gopa sir will confirm it.
Yeah, I think it is the same way.
Yes, sir.
Sorry, sir.
Okay. So now your movement range is?
So I could measure from 0 to 45 degrees in both active and passive range. It was painless.
Any extensor lag?
There was no extensor lag, sir.
What is causing this limitation? Is there a bony block?
So there was a bony block to the movement, sir.
Bony block is there.
Yes, sir.
How do you say it is a bony block on examination?
Sir, after the active, at the end of the active range of motion, I cannot passively flex the knee further.
So there's a hard end point.
Hard end point, sir.
Okay. Yes. Anything else in the movement you want to say?
Sir, I have not taken the photographs of the rotation. There was a limitation of internal and external rotation compared to the contralateral side, sir.
Rotation of knee joint.
Yes, sir. In flexion, sir. In flexion of the knee, internal and external rotations.
Is it common for you to examine for rotations of the knee joint?
What are the freedom of movements or the ROMs that occur at the knee joint? It is just flexion extension.
Flexion extension and in extension of the knee, coronal plane movement are very minimal, sir. It is not testable. Adduction, abduction. In rotation, sir, with knee in flexion, that is also minimal, sir.
So do we comment on that?
No, sir.
Why land in a soup? Okay.
Measurements?
Sir, in the measurements, there was a circumferential wasting of 2 centimeters in the thigh muscles. There was no limb length discrepancy on either side. And I've measured the Q angle, sir. On both sides, it was comparable. It was around.
What are prerequisites of Q angle?
So, there should not be patella alta, unilateral patella alta or patellar hypoplasia.
No, in which position of the knee you look for?
So, 30-degree of knee flexion, sir.
Why?
Sir, because in that position of the knee, the patella will fit in. It will sit in the trochlear groove, sir, and will not displace. So it will be easier to measure, sir.
Any instability you can continue.
Sir, I have tested for since the patient was not able to flex beyond 45 degree, there was a bony block to movement. So, sir, I can only elicit the Latchman test for stability. I did not find the Latchman test was negative, sir.
And what about MCL and fibular collateral ligament, LCL and LCL?
Sir, there was no mediolateral instability, sir.
How do you test for medial collateral ligament injury?
So I'll give a valgus test to the knee in 0 degree of in full extension of the knee, then at 30 degrees of knee flexion and at 90 degrees of knee flexion, sir.
So in 0 and 30, did you examine this?
Sir, I could not put up the photographs.
No, did you do it?
Sir, yes, I've done, sir.
Okay. So what was your interpretation of that test?
Sir, it was symmetrical on both sides. There was no mediolateral laxity on the right side, sir.
Okay, with so much of adhesions, were you able to do the test?
Sir, I tried to do it, sir.
Okay. Anything else?
So I could test for the Latchman test, which was negative, sir. I could not do the anterior drawer test because the patient was not able to flex beyond 45 degree.
Okay.
And also I could not see for the PCL ligament sag sign or the Godfrey sign, sir, because the knee was not being able to flex beyond 45 degrees, sir.
Okay.
So then I have done some special tests like the OVERS test for testing the iliotibial band contracture, and I found it to be positive, sir.
Okay.
And also I've done for the Ellis test in prone position of the patient. From the Ellis test, I could infer that there was no involvement of the rectus femoris because the hip on the involved side was not flexing on attempted flexion of the knee.
But again, there is only 45-degree flexion, isn't it?
Right, sir.
So, how will you interpret a Duncan-Lee test with 45-degree flexion?
Okay.
And how did you do the Ober test?
Sir, first I've made the patient on the left lateral position on the bed, and I've stabilized the pelvis by putting my hand across the iliac crest. Then I've held the right lower limb by placing my hands over the medial side of the knee, and I've tried to extend and abduct the hip, and gradually started adducting the hip towards the bed of the patient. And while adducting, during slow adduction, the patient was, when I left the right hand, the patient was not able to adduct the limb completely to the bed.
Okay, on the right side, how much flexion are you getting in this picture?
So it was 45-degree, maybe because of the angle of the photograph. It's looking.
Okay. So it appears to be much more here in this picture.
Yes, sir.
Because you are extending the hip and then flexing, and still you are getting reasonably good range of flexion. Okay.
Yes, sir.
Why is Ober test significant in here? Why did you look for it?
So actually, the index surgery which patient had undergone was through the anterolateral approach to distal femur. And following the surgery, he had started developing symptoms of loss of knee flexion. So there could have been a possible involvement of the iliotibial tract, sir.
Okay, is it a common cause for involvement of the iliotibial tracts in the lateral exposure of the femur?
I'm not sure, sir.
What is the other common cause? When you fix fractures through the lateral approach, you get stiffness, isn't it? What's
Yes,
the cause?
Sir, there can be myositis, sir.
Not myositis?
Myositis ossificans, sir.
No, not
No.
common.
Something really very common.
You are elevating cordyceps, isn't it? You are elevating the cordyceps.
Yes,
and
sir.
therefore, what will happen? There can be adhesion between the cordyceps and the femur. If he doesn't go for post-operative physiotherapy, which you have said due to COVID conditions, he was not able to do.
Yes, sir.
So, what do you want to do now?
So I would like to confirm my diagnosis. By doing some, I would try to rule out infection by doing a
See, the
routine.
one question which comes to your mind is there was a fracture which was fixed.
Yes,
okay.
Sir. Yes, sir.
So, is it due to an intra-articular cause or an extra-articular cause that this stiffness has occurred?
Yes, sir.
Which one, according to you?
Is it intra-articular or extra-articular cause of stiffness?
Sir, it is an intra-articular cause, sir.
Why do you say so?
So because there is a bony block to the movement, and both active and passive range of movements are same.
Okay. So you want to confirm whether there is a bony block or not. So for that, what
Yes,
you
sir.
want to do?
So I would like to order an X-ray of the patient, sir. Both AP and lateral view of the X-ray.
Okay.
X-ray of what place? Hip joint?
No, sir. X-ray of the right knee joint, sir, showing distal part of the femur and proximal part of tibia, sir.
Okay. Standing, lying down?
So in standing, the AP view in standing position and the lateral view in 30 degrees of flexion, sir.
Why?
Sir, in 30 degrees of flexion.
Why standing AP?
So in that case, the patella will look forward.
Now here it is an extra stiffness of the knee.
Yes, sir.
You are evaluating stiffness of the knee and a fracture, isn't it?
Yes, sir.
So why do you want to ask for, which X-ray do you want to ask for?
So X-ray of the right knee joint with showing the distal part of the thigh, right thigh, and the proximal part of the right leg, sir. So because a patient had undergone a surgery 2 years back, sir.
Which are the views do you want to take?
Will you go for an axillary or a skyline view?
Yes, sir. Skyline.
Okay. Why?
So I can see the patellofemoral articulation, sir.
Have you got the X-rays?
So I've just got the AP and the lateral view, sir.
Yeah.
So this is a skygram of the skygram showing the AP view of the right knee with distal part of the right thigh and proximal part of the right leg with fixed angle device in situ, possibly a dynamic condylar screw, sir.
Yeah.
And there is a radiopaque shadow over the medial aspect of the distal femur arising from the cortex. And there is no.
What is the shadow?
Sir, it may be, sir. It may be an heterotrophic ossification, sir.
Or is it just callus?
I'm not sure, sir. Actually, it is invading the soft tissue, sir. So.
Okay. What has happened to the fracture?
Sir, the fracture seems to be united, sir.
Where was the fracture? Intra-articular or extra-articular?
Sir, extra-articular, sir.
So his problem is stiffness. What do you want to do?
Sir, I would like to go for an arthrolysis.
See, it is, according to you now, it is an extra-articular problem, isn't it?
Yes, sir.
And arthrolysis, according to you, was already done.
It was already done, sir. By,
what is MUGA? Manipulation under
general anesthesia, sir.
Will you offer that to him? Because it's hardly 20-30 degree of movement that is lacking.
So I don't think it will help much because the patient is having
what is the complication? What is the dreadest complication of doing a MUGA?
So there can be an arthrinic fracture.
Okay, and if the patient does not do physiotherapy or is not going on for CPM after that, there can be further stiffness because of the hematoma caused because of MUGA.
Okay, sir.
Okay, so now you want to do is?
Sir, yeah, I would try to go for an open arthrolysis, and if still the range of motion on table is not enough.
So how will you do this open arthrolysis?
So I would open the right knee joint through the previous surgical scar.
Previous scar. Okay.
That scar is on the lateral side, isn't it?
Lateral side, sir.
It is mainly in the distal femur and not exposing the knee joint. So,
preferably
you modify your term arthrolysis with something else?
So, Arthrotomy, sir.
No, now you know that it is an extra-articular problem.
Yes, sir.
So do you want to modify the term arthrolysis with something else or substitute it with something else?
So I would like to go for a quadriceps plasty.
Yeah. Quadriceps plasty. Okay. So you can do one of these quadriceps plasties, and then you may have to remove the implants also. Okay. What is the name that is given for the extensive quadriceps plasty done for such cases?
So it is a Thompson's quadriceps plasty, sir.
Thompson's is only anterior, isn't it? That will not help here.
Okay.
This Jude. Jude's quadriceps plasty.
Okay.
Yeah.
Okay.
What about Sengupta's quadriceps plasty?
So in Sengupta's quadriceps plasty, there is a release of there's proximal release of quadriceps.
Which muscle among the quadriceps is released?
So the vastus lateralis.
Vastus lateralis.
Or rectus femoris.
Rectus femoris. I'm sorry, sir. Rectus femoris.
Rectus femoris has two heads of origin.
Yes, sir. So direct head and the reflected head, sir.
Yeah. So which one is erased from its origin?
So
you don't go up to acetabulum. You don't go up to the acetabulum.
So from the shaft of the femur, sir.
Yeah. Okay.
Sir, there seems to be intra-articular fracture, sir. Intra-articular, this T-type fracture. If you see carefully, this is the fracture.
A small step there, eh?
Yeah.
Yes, sir. I will annotate, sir. This one is the fracture line, sir. And this is the fracture line.
Yes, sir. There was an intercondylar screw also there, sir. The additional screw is there apart from the DCS.
And DCS screw is shorter. DCS screw is shorter. The patient is lucky of getting united. Intercondylar fracture area, threads are there. Screw should have been longer. And there was intra-articular combination, sir. Intra-articular extension. Maybe type B1 or B2.
Okay.
Sir, there is one question, sir. If you permit, I will ask. Repeatedly, one student has asked how to use the goniometer from lateral aspect.
Gopal.
Sir.
Answered him.
Yes, sir. I think he was not awake at that time. Again, he has asked the same question.
No, I've answered him individually. So from the center of patelline extension, if you go on medial and lateral side, corresponds with the joint line. So equidistance from both the sides, you put the goniometer medially or laterally wherever you want. Usually, if there is an implant on lateral side, it is preferred that you go from the medial side. But because lateral is easily palpable, for that reason, it is kept on lateral side.
Sir, is it from the center of patella or lower pole of patella, sir?
Center of patelline extension corresponds with the knee joint. See, put it in yours. Do it that way.
Right, sir.
Okay. Anything else?
Sir.
I think we finished in time, eh?
Yes, sir.
Yes, sir. Shall we ask the questions from comments from other faculties, sir?
Sure.
Shivananda, sir.
Gopal, this
Yes,
is
sir.
how me and Gopa Kumar sir usually take exam. We finish very well.
Yes, sir. Yes, sir. Yes, sir. सर मैं बोलने वाला था टाइम खत्म हुआ है ऑलरेडी 7:45 को स्टार्ट किया था तो ऑलमोस्ट 40 मिनट्स हो गए पहले वाले को हमने भी 40 मिनट्स ही दिए थे एकदम सही टाइम पे हुआ है सर मैं रिक्वेस्ट नाउ Shivananda sir.
He could not see anything. He said there's nothing visible on his screen.
The problem with this maybe the connection.
Net might be net connection issue, sir. Otherwise, how could he write the message to us? Okay. Then, Kanoja sir, about both the cases. Sir, unmute करिए.
I think adhesions are because of intra-articular fracture and lack of this physiotherapy. That is the main cause of adhesions.
So I think yes, sir.
Properly.
Net connection is poor, sir, for you.
Yes, sir. Any intra-articular fracture, I think students should remember in exam that intra-articular fracture fixation means delayed weight bearing till fracture unites, but early active range of motion as early as possible. I think, sir, no one is there. Other faculties. Uday Kumar, sir, he was already. Yes, sir, you are already examiner, sir. So I think no other faculties are there. आप comment कर सकते, जैन sir comment कर सकते, and then I will take concluding remark from Gopa Kumar sir.
Sir,
Samanta sir is there.
No, I am there. I am listening from the very beginning.
Oh, sorry, sir. I think बच्चे के phone से शायद sir ने एक मिनट मुझे देखना.
No, उसीलिए no problem. I that's why I text Jayan's bhai. I was there from the very beginning.
Sorry, sir. Your comment, sir. Your comment, sir.
No problem. I think they presented very well by the for the first case also. It has to be very sequential manner because there was a gross mistake in the second slide. How is the habitual dislocation? There is no point it should be written like that. Like so, like in the first case also, he was telling the shoulder range of movement was okay. They are not nearly normal. So might be you have not examined the patient properly yourself because of the COVID, but say it can't be normal. So I request all my juniors, please practice yourself so that it looks nice during the presentation.
Rikudeep, I want to give you one advice. For every test, you should know the method of doing the interpretation and drawbacks. Almost all the tests you have to read that.
Yes, sir.
In first case, sir, there was whenever there is restricted range of motion, we should not utter unless asked. Either it is a recurrent dislocation or habitual dislocation. Habitual dislocation as such is out of question for means by any imagination. If at all you want to comment about recurrent dislocation,
okay. What is by definition habitual dislocation, and how it is different from recurrent dislocation?
So in habitual dislocation, the patella dislocates every time the knee flexed.
With every movement of flexion extension.
So with flexion, sir. Every time the patient flexes the knee, there will be a dislocation of the patella laterally.
Okay.
So that is and recurrent.
And when it is it due to trauma?
No, sir. It is usually present since birth, sir.
Then it should not be told. That's what I mean.
Sorry, sir.
Then what is recurrent dislocation by definition?
Sir, recurrent dislocation, it is usually having an antecedent trauma, and following that, the patient, the patella dislocates during a particular arc of movement, sir.
So was it relevant here?
Sir, I would have word, sir.
You should not have used recurrent unless there was something in history. It is a short case.
In short case, White tells negative diagnosis.
In short case, after diagnosis, usually we go for relevant positive findings, and if at all any important negative finding which will in diagnosis. Otherwise, okay.
Okay, sir.
I will request Gopa Kumar sir now to
First case, there was a blunder saying that two rush pins were put through the shoulder into the humerus, and it was removed 1 week back, so that it will be painful. And still he was telling there was full range of movement of the shoulder. In the second case, unnecessarily he location into the diagnosis. Because once you get such a thing, some examiners will go in behind that, okay? Then they will start regarding the definition of habitual dislocation, what is congenital dislocation. Like that, they will take you to a different area. So it is much better to use, restrict your words in such a way that it is related only to your diagnosis. Okay? Otherwise, it was a good presentation, and both of them, I think, will get through.
Recording stopped.
thank you, sir.
Okay. So let's call it a day.
Yes, sir.
Okay.
Thank you, sir.
Yes.
Thank you, sir.
उदय कुमार
Thank
सर
you,
मास्क
thank you.
मास्क लगाए हुए
Tuesday,
में है क्या?
Tuesday 7:30 p.m. Tuesday 7:30 p.m. 1 to 1.5 hours class on revision
Radiology.
of radiology,
Sir,
and
sir.
will be concise this time. Will not be like last time.
Gopal, do you have recordings there for the ward rounds?
Yes, sir.
Yeah, you can put it one day. I will also sit, so that there is no
No,
need
no
for.
issues, sir. Oh, आपको भेज दूंगा सर मैं. आपको भेज दूंगा सर मैं.
Sir,
Sir,
good news is
sir,
today-
for some specific class, a specific student was insisting the recording, which I discussed with the concerned faculty, and it is decided not to give. Student
for
is
the-
also right now listening, so I end this matter here only, and the relevant student is. I have sent him message personally also, and now also he is listening. But what round, sir? I will put in faculty group also and
No.
in students group also
Like-
today itself.
No, it is not like that, sir. In one of
Yeah,
the
he
class,
was. Sir was giving. He was in a humor.
you can.
Right, sir. It is there, sir. It is there.
So what you will do
In that case,
is one of these days during our
Sir.
class, you can put this video, and after each, say example splints, you can stop so that we will answer the questions of the students.
Yeah,
Alright,
that
sir.
would be
Then
better.
what?
That will
I
be-
think this is good idea, sir. Last time's complete recording is with me. I will put that recording link.
No, simultaneously chalne dene ka. Like
Okay,
recording going on and sir is going to answer the question.
Yeah.
No problem, sir. Then there is no need to give the talk or take
Yeah.
help of only recording.
Yes.
Instead of me speaking,
Thank you very much, sir.
That is what sir said. I will also see.
Gopal,
Thank
you
you
can
very
also
much.
do that. Gopal, you do that. You put few X-rays and tell one student to read that X-ray and then correct it.
Right, sir. Right, sir. Presentation
That
is
would be
there.
an
Then
interactive
rather
class.
than right, sir. Then rather than I give the talk, I will keep shifting the X-rays, and senior faculties will keep asking the questions on those X-rays.
okay.
Yes.
No problem, sir. Tuesday will be X-ray day then. X-ray
Okay.
revision day.
Okay. The next Saturday, I think so. One of the students is presenting a rickets case, Jenu Veres rickets.
Okay.
All right, sir. Sir, one long case, one short case seems to be good combination, sir.
नहीं इनका एग्जाम में लॉन्ग केस नहीं है
ओके, ठीक है सर, ठीक है सर. देन इन दैट केस वी कैन मैनेज 3 शॉर्ट केसेस सर, अगर इंटरेस्ट दिखा दे तो.
वो
अभी भी
टाइम से
40,
खत्म,
we have not crossed 50.
प्रेजेंट
I
तो
have not
करना
crossed
चाहिए.
50.
आज जैसा
सर,
टाइम से फिनिश किया तो हो जाएगा.
सर मैं होने एक्सटेंड होने नहीं दूंगा सर
Very good.
डिस्कशन. मैं एक्सटेंशन होने नहीं दूंगा. 25 मिनट से ज्यादा टाइम ही नहीं देने वाला है.
ओके.
जो भी एग्जामिनर हो गए उनको रिक्वेस्ट करूंगा 5 मिनट पहले बोलूंगा भी बीच में कि सर 5 मिनट बचे.
वो सेमिनार में केस प्रेजेंटेशन, वो प्रेजेंटेशन में स्लाइड्स ऑफ.
राइट सर. सर मेरा रिक्वेस्ट है स्टूडेंट्स के लिए कि आप लोग शॉर्ट केस अगर है तो प्लीज स्टार्ट विथ माय डायग्नोसिस इज दिस व्हिच शुड इंक्लूड एनाटॉमिकल, पैथोलॉजिकल and present disability, how he is disabled. 3 points important, and then they should go with cheap positive findings. Cheap positive findings in history. If at all it is very important negative finding which will give you a hint for the diagnosis, that only, otherwise no negative finding. And then look, feel, move, measure, special tests. Involve only to these areas. And lastly, don't forget to mention about relevant contralateral same and proximal and distal joint and spine in one line. And their students should stop actually. So this is request to all the students. Right, sir. Thank you.
Okay.
Right, sir. थैंक यू वेरी मच सर. गोपा कुमार सर अगेन, आप जब भी रहते हैं सर मैं सबसे ज्यादा रिलैक्स हो जाता हूँ. थैंक यू वेरी मच.
ओके, बाय बाय.
बाय सर, बाय, गुड नाइट. Samantha sir, I think sir left.
उदय कुमार सर गए.
नहीं,
हाँ, शिवानंद सर है.
शिवानंद सर है.
हाँ, और
उदय कुमार ऑडिबल.
Yes sir, loud and clear.
Okay sir.
This is our post-operative meeting.
Post-operative meeting. Good sir, post-operative meeting.
Students, you please can exit yourself.
So what I'm unable to see is on the screen. Why sir? What is the problem in this? Gopal sir?
Your
problem was वो blank में गया था आपका. जहां भी आपका फोटो है ना सर, उधर कुछ तो बटन दबाया गया होगा, उसकी वजह से वो ब्लैंक में चले गए थे. वहां एक वर्चुअल ब्लड बोल के आता है सर, बैकग्राउंड ब्लड होता है.
हाँ, बैकग्राउंड ब्लड हो गया. exactly.
तो इसका मतलब है वहां एक बटन होता है सर. अभी आप आपके फोटो पे जाइएगा, राइट क्लिक करिएगा आपके इसमें. हाँ, उस सीधा वो पिक्चर में जाके या म्यूट के बाजू में 3 डॉट है, उधर जाइएगा.
3 डॉट
उधर आएगा चूज वर्चुअल बैकग्राउंड, चूज वीडियो फिल्टर, स्टॉप वीडियो.
सर दिस इज आई एम वाचिंग
और हाइड सेल्फ व्यू. सर हाइड सेल्फ व्यू बोल के एक बटन है नीचे. गलती से अगर ये हो जाता है ना तो आप रीजन होते हैं आपका. अभी देखिए मैं हाइड सेल्फ व्यू कर रहा हूं मेरा.
Okay. I could not able to see anything today.
उसकी वजह से हुआ होगा सर, और कुछ वजह नहीं है. Okay sir, with everybody's permission, shall we call up the
sir? Kanajay sir. हाँ बोलिए. How can I get that plan sir?
मैंने बोला ना आप आओ घर पे.
But really it is so nice sir. It is very nice.
It was so nice. And that comes from the leaf, you know.
Yeah, that comes from the leaf. Yeah.
Sir,
margin of the leaf.
Ashok Sham is there. Ashok Sham sir is there. या student है कोई और?
Ashok Sham.
Someone is Ashok Sham. I don't know who is, whether student or Dr. Ashok Sham.
I don't know sir.
वो प्लांट मैं भेजता हूँ आपको.
सर क्या
आएगा उधर.
राहुल, अशोक श्याम, जानकी एंड राम विवेक, प्लीज लीव द मीटिंग. आई थिंक ये जो बच्चे हैं ना वो ऑन करके प्रेजेंटेशन प्रेजेंस दिखाने के लिए भूल गए लगता है सर.
I will try to get it, sir.
Yes.
Hello?
Or it's very good for once in a year only for 4 to 6 hours.
Okay, sir.
मैं देखता हूँ और it will come there also.
Yeah, I will try to get it. If I get it, then it is good.
नर्सरी में मिलता है सर, नासिक में। नासिक में नर्सरी में मिलता है सर, ये छोटा
उसका लकड़ी भी लगा दिया तो भी आ जाता है।
लकड़ी से भी सर? ओके।
तो हमारे यहाँ 1-2 थे, अभी तो बहुत हो गए, बच्चे हो गए।
ओके सर।
हम आपको एक पिक्चर भेजेंगे, हमारे यहाँ बहुत चिड़ियों के घर है, बच्चे अंडा देने से लेके फाइनल उड़ने तक।
ओह, अंडा है ना?
From eggs, laying the eggs until last they fly away from the nest.
Okay.
वो गुड़ पे डाल देंगे, बहुत अच्छा। 2 अंडे बच्चे हुए, थोड़े दिन बाद उड़े और बैठ के चले गए।
Yes, sir. Okay, sir.
चलो, let us say bye.
Bye, sir.
ना मोबाइल है तो प्रॉब्लम अच्छा।
सर मोबाइल का प्रॉब्लम नहीं था, some setting issue was there, sir.